Welcome to this deep dive. This one's really geared towards you, the specialist clinician. Today, we're unpacking something pretty routine, right? Non-invasive blood pressure monitoring.
Right. Something we do all the time.
Exactly. But you might feel like, it's second nature. However, the source material you shared, this specific protocol, actually from a vascular surgeon's practice, it shows there are some, well, critical details even here.
And, understanding these nuances is absolutely essential. This protocol isn't just a checklist. It really distills deep clinical insight into the why we do things a certain way for certain patients, especially those with complex vascular issues.
Correct.
So our goal here is really to connect those instructions, the steps, directly to the underlying reasons, because missing these specifics, well, it can definitely impact patient outcomes.
Okay, so let's get into it then. Starting with limb selection. The protocol you gave us is, well, very clear on the preferred site. What does it say should always be the first choice?
Yeah, it's unambiguous. The protocol mandates the right arm. Always the primary site for an NIBP.
Right arm first.
Okay.
And what about when you can't use the right arm? What criteria does it outline for those situations?
Well, you'd have to move away from the right arm if there's, say, a history of recent surgery on that specific limb.
Okay.
Or maybe a recent endovascular intervention there. Also, if the brachial pulses are absent or, significantly weaker compared to the other side.
Pulses, right.
And obviously, if the limb just isn't there, physical absence.
Got it. So if the right arm's ruled out by one of those, the next logical step is the left arm. Does the protocol basically apply the same checklist to the left arm?
Exactly the same.
Yeah.
If you're considering the left arm because the right's contraindicated, you run through that identical assessment. You check for recent surgery, recent endovascular work, pulse quality, absent or weaker, or again, absence of the limb itself. You have to assess the limb you're choosing based on its own status.
Makes sense. Now, the protocol gives a specific reason for starting with the right arm, doesn't it? Why is it right over left as the default?
It does, yeah, and it's rooted in the patterns of peripheral arterial disease, PAD.
Okay.
So PAD, it mostly hits the legs, right? Upper extremity arterial disease is actually pretty infrequent. We're talking less than 10% of patients with PAD.
Less than 10%. Okay.
But here's the crucial part. In that small group who do have upper limb issues, it's overwhelmingly more common and more significant in the left arm.
Really? How much more common?
Something like 90% of those cases affect the left side compared to the right. So by starting with the right arm, you're minimizing the chance you're measuring pressure through an artery already compromised by PAD.
I see. So it's about getting a more accurate reading, one that reflects systemic pressure better.
Exactly. You're playing the odds based on disease prevalence.
Yeah, it really clarifies that link. Okay, let's switch gears slightly to avoiding lower limb measurements. The protocol seems quite firm on this. When does it absolutely say don't use a leg?
Yeah, it's pretty strict. You absolutely should avoid lower limbs for NIBP if the patient has diagnosed PAE.
Okay, PAD specifically.
Well, also coronary artery disease, CAD, or cerebrovascular disease, CVD, these often go hand in hand.
Right, comorbidities.
And in patients with PAE affecting their legs, taking a pressure there is very likely to give you a falsely low number compared to their actual central blood pressure.
Because of the reduced flow.
Exactly. The narrowed arteries just don't allow for an accurate measurement with a cuff.
Okay, so inaccuracy is one reason. But beyond that, the protocol flags a really critical warning, doesn't it? Something potentially dangerous with lower limbs.
Yes. And this is absolutely vital. Cannot stress this enough for safety.
Okay.
The protocol explicitly warns, do not apply a blood pressure cuff to any limb, leg, or arm, actually, that has undergone recent vascular surgery or recent endovascular procedure.
Recent being the key word there.
Absolutely. It states this must be avoided because the external pressure just from the cuff inflating. It could directly cause an arterial thrombosis, a clot forming right there in that freshly treated or repaired artery.
Wow, so it's a direct mechanical risk from the cuff itself.
Precisely. It's not just about getting a bad number. You could actually cause serious harm.
That is a really stark, important warning. Okay, so let's try and pull the key takeaways together for you listening. The main rule: measure on the right arm. Unless specific things rule it out, like recent surgery, intervention, no pulse, or no limb.
Right.
If the right's out, you assess the left arm using that exact same checklist.
Correct.
And critically, avoid lower limbs in patients with PAD, CAD, or CVD because of inaccuracy. But the absolute no-go is any limb with recent vascular surgery or endovascular work.
Because of that thrombosis risk.
The direct clotting risk, yeah.
And you see how this protocol, it really connects that everyday action, taking a blood pressure, to the patient's underlying vascular health and specific risks.
It really does.
It's grounded in, how diseases like PAD usually present, and also the direct physical impact our actions can have on blood vessels that are frankly vulnerable after procedures. Understanding that why makes the protocol so much more powerful in practice.
It elevates it, doesn't it? From just a task to a point of critical thinking about the patient's history and potential risks. Okay, so as you, our listener, reflect on this deep dive, maybe consider this point. Given that very specific and quite severe risk of arterial thrombosis we just talked about for limbs with recent vascular procedures, how does knowing that detail specifically shape how you communicate or document things during handover? Or, when you're planning care regarding limb access and where it's safe or unsafe to place a cuff in your setting, something to think about.